Welcome everybody. I'm Dr. Sadaf Ahmed. I'm Associate Professor and HOD of Dermatology Department at DIMC. Today we'll be doing two topics, basic skin lesions and scabies and pediculosis. And at the end of the lectures, we can continue with all the questioning and everything. So that shouldn't be a problem. So starting with the basic skin lesions, what do we mean by them? Basically, throughout the world, there are certain descriptions for the skin presentations that the patient presents with. These are universally accepted so that when you present a patient clinically with the terminologies, they're similar worldwide. And one word means the same for everyone throughout the world. So that is the reason why we're trying to clear out your concepts on what these lesions are, so that when you come for your clinical rotations and during your examination as well, you will be using these terms to specify the lesions and the presentations of dermatology patients. So first of all, a basic outline. This is a very gross view of the basic skin. The upper layer is the epidermis, then we have the dermis and the subcutaneous layer, or the hypodermis as we may call. And the epidermis has its own 5 layers. And then we have the dermis, which has 2 layers, but basically the 5 layers. When we describe the skin lesions, we are doing them in conjunction with all these structures because different layers present differently. And this is the stratum corneum, the lucidum, which is present only in the palms and the soles, the granular layer, the granulosum, the spinous layer, and this is the basal layer. Okay, the skin rejuvenates in the basal layer and it moves from the base to the top in this manner, taking about 28 to 30 days for each layer to get rejuvenated. So the skin lesions are basically two types: the primary lesions, the primary presentations, and the secondary lesions that occur due to changes in the primary lesions. These are the different terms that we will be studying one by one, and we will try to address as to what they are and how they present. We're not focusing on the diagnosis of the disease, just the presentation of the lesions as to how they present. So first of all, a macule. What we mean by a macule, it's a flat area on the skin which is less than 1 centimeter in size. It could be 0.5 to 1 centimeter, but to be on the safe side, we say less than 1 centimeter in size. It could be a discoloration or a change in the texture, but it is never raised. Okay, if you can feel a raised lesion, it is not a macule. A separate term applies for that. So over here, if you see a small lesion less than 1 centimeter on the surface, which could be either a change in the color or a change in the texture, is called a macule. But if the same lesion is more than 1 centimeter, it is called a patch. So they're both interchangeable. A small one is macule and a larger one is called a patch. But the condition common would be that they would be flat and they will not be palpable. This is how they present clinically. You can appreciate the tiny macules, pigmented macules. Here again, it's a macule which is increasing in size. Multiple macules which are coalescing to form patches. Okay, so this is how they present clinically. So when a patient comes to you, you will be saying, in this patient, you will be seeing multiple hypopigmented macules and patches, okay, on the back of the patient extending up to the neck. Similarly, patch, as I described, is a lesion which is more than 1 centimeter in size, but it is flat. Okay, it could again be a change in the color or a change in the texture, but it will never be raised. Or you can say a larger patch, a macule is called a patch, or a smaller patch is a macule. It's quite visible as well that it's flat and it's not raised. And this is whitish in color. So they can be different presentations. Now, a papule, if the macule becomes palpable, it's going to become a papule. It's going to be termed as a papule. So a raised lesion less than 1 centimeter in size is a papule. It involves papule. You can see raised lesions present on the fingers. And these are coalescing to form something else. Okay, but these individual ones are raised lesions about 1 centimeter in size, and these are called papules. It could be any color, that is irrelevant, but it has to be raised and palpable. So again, if the lesion is raised and it's less than 1 centimeter or up to a centimeter, it's a papule. But if it is more than a centimeter or larger in size, it's called a plaque. So this is the main difference among the two. You can say a raised macule is a papule and a raised patch is a plaque as well. So this way, the terms can be used to understand better. As I mentioned, a raised elevated lesion more than 1 centimeter in size is a plaque. Similarly, more pictures, a plaque could be of more than 1 centimeter, but to any size. It could be 5 centimeters, it could be 6, but it has to be more. Here again, you can see a raised lesion, palpable lesion. Okay, a pustule. A pus-filled lesion in simple terms is called a pustule. Okay? You can see tiny pustules of variable sizes, and you can appreciate the frank pus in them. So these are called pustules. Okay? They are superficial lesions filled with pus. However, if they are deep lesions, not so visible, but deep pus containing lesion, that will be termed as an abscess. So pustules are very superficial pus containing lesions, and if they become deep and pus filled, then they are called abscesses. A nodule is a palpable or solid swelling present inside the skin. It is usually more than 1 centimeter. It is better felt than seen. On the surface, you may just see a raised lesion, but when you feel it, you can actually appreciate its thickness. And it may be extending to the dermis, deep dermis, and subcutaneous tissue, depending on what the etiology is, but they are raised swellings present inside the skin, involving all the layers of the skin. A wheal is a transient edema of the dermis. Okay, one of the properties is if you apply pressure, it blanches. That is, it disappears and then it reoccurs. In simple terms, we call them hives as well, most commonly seen after insect bites or allergic conditions, but they are because of transient edema of the dermis, and they're usually itchy and erythematous. Okay, vesicle or vesicle, these are tiny fluid containing lesions present on the surface less than 1 centimeter in size. If the same thing becomes more than 1 centimeter, it is called a bulla. So you can see tiny vesicles and they're coalescing to form bullas over here. In general term, fluid-filled lesion is called a blister, but that's a very vague layman term. When we're talking in dermatology, we call it a vesicle or a bulla. Here again, you can appreciate vesicle fluid. This has to be clear fluid, okay? And if it becomes larger, more than 1 centimeter, it is called a bulla. Now we come to the secondary skin lesions. These secondary lesions are seen in association with the primary lesions. These are the different terms that we will be focusing with description. So we'll go on them one by one. Stratum corneum. Stratum corneum is the topmost layer of the epidermis. It is comprised of keratin. So the dried flake is called the scale, which is seen in or appreciated in a number of conditions. In this picture, you can see these white scales present on top of a plaque, an erythematous plaque. Okay, as I mentioned, things. Scales could be dry, scales could be greasy, they could be adherent, they could be loose, depending on the type of disease you have or the presentation. But in simple terms, scale basically means a dried flake of skin, the topmost layer of the skin. And to be more specific, stratum corneum. Okay, a crust is simply dried exudate. This yellowish dried exudate is called a crust. It is superficial and usually not painful or anything, usually follows an infection of the skin. However, if it is deep, adherent, and thick, it is called a scab. So a crust is superficial, a scab is deep. And if you remove a scab, it's usually on a more deeper lesion, and a crust is on a more superficial lesion. Okay, lichenification. Now, if you find these are usually seen following chronic itching or chronic lesions, which are associated with a lot of itching or pruritus. You will see 3 features cardinal in this. One is going to be thickening of the skin, which happens because of prolonged itching. There could be increased pigmentation of the skin and exaggerated skin markings. You can see the normal skin markings are pretty exaggerated or hyper magnified in this condition. This is called lichenification. So these 3 features would be present in cases most commonly seen with chronic eczema. But if you have a chronic itchy condition, it could lead to this clinical appearance termed as lichenification. Excoriation in simple terms are simple scratch marks. Okay? Superficial scratch marks are called excoriations. In this, there is just abrasion of the stratum corneum, nothing more. However, if there's more loss of the skin involving layers of the epidermis, deeper layers of the epidermis only, it is called an erosion. If it progresses further deeper to the dermis or even deep, it is called an ulcer. So you can say this is loss of the surface of the skin. If it is just to the upper layer, stratum corneum, involving the layers of epidermis only, it is an erosion. And when if it is further deeper, extending to dermis and beyond, it is called an ulcer. So ulcer, as I mentioned, you can see it is deep and it usually heals with a scar. The deeper you go, the more the scarring is prominent. And this is an erosion, and if it's deeper, it's an ulcer. Here again, this is an erosion. It is involving layers of the epidermis. This is an ulcer. It is going beyond the epidermis, deeper into the dermis and to the subcutaneous tissue. And this is fissure. Fissure means longitudinal slit in the surface of the skin. It can go deep or anything, but it is seen as slits in the skin surface. Most common example is the cracked heels, which we see in older patients mostly, or people who don't take care of moisturizing their skin regularly. Again, loss of focal epidermis, which does not go beyond the epidermal, is the erosion. And if it penetrates deeper to that is dermis and beyond, it is called an ulcer. You can appreciate the difference. See, the ulcer looks deep and more aggressive, whereas the erosion looks more superficial. Although it's VP and red and everything, but you can appreciate the difference of morphology. Okay, fissure, as I mentioned, these are longitudinal slits or cracks in the skin. It could be limited to the epidermis, it could extend to the dermis or even deeper. And the deeper it goes, the more painful it becomes. Okay, usually associated with dry conditions of the skin. Comedones. Okay, this is a term which we come across most commonly in patients with acne. So comedones, we are common with the regular terms such as blackheads and whiteheads. These are the blackheads and these are the whiteheads. The blackheads are the open comedones, the whiteheads are the closed comedones. Comedone by the term means keratin plugging the pilosebaceous follicles. That is the clinical description. And the black color is because of melanin, it is not because of dirt. And the white ones are closed because they haven't been exposed yet, they are open yet. You can find both of them in the individuals or more in one and the others. And these are the pathognomic hallmark of acne. These are the primary or the most characteristic findings of acne lesions. The burrow we will discuss further on as well, as the second topic is scabies and pediculosis. Burrow is a C or an S-shaped tunnel which is produced by the burrowing action of the scabies mite into the stratum corneum, as you can see here. It produces this tunnel to copulate and lay eggs, and responsible for the typical lesions clinically. This is one of the lesions seen on magnification, which is called jet and contrail sign of scabies, and that we will discuss further on as well. But burrows are very characteristically appreciated in scabies patients. One of the diagnostic clues, actually. Now, these are another term that we can say. Hematoma is accumulation of blood under the skin. Petechiae are pinpoint hemorrhages into the skin, very minute pinpoint hemorrhages. Purpura are usually more than 2 mm, hemorrhages in the skin, but usually more than 2 mm to 2 centimeters. And if it's more than 2 centimeters, it is called echivosis. So these are the names are changing in order of increasing sizes. Petechiae are the minutest, then the purpura, and these are the larger extravasations. And hematoma is a collection of blood under the skin. It's like a ball. So petechiae, as you can see, these are really minute pinpoint hemorrhages into the skin. These are larger and more erythematous red, so you can see their purpuras. And then these are large echymoses. Okay, the color changes of bleeding will be appreciated in both these situations, depending on how extensive it is. But according to the size, the name changes. So now when you define the clinical terms, you will be dermatological presentations. You will be using these terms for your presentations. Okay, this was the first part. Now we will proceed on to the next part, which is scabies and pediculosis. Okay, so as we start these, we know that scabies and pediculosis are one of the commonest presentations in the dermatological OPDs. Scabies and pediculosis itself comprise about every 6 to 7 patients presenting in the OPD out of 10 have either scabies or pediculosis. It is that common. It is endemic in the southeast of Asia. So you see it really common. It can present with along with other conditions as well. For example, if a patient presents with psoriasis, he can have concomitant scabies or pediculosis. It's not that if you have one, you cannot have others. So in that way, the load of these diseases is pretty high in our clinical presentations. One more thing, the lectures given are quite sufficient for your consultation for clinical terms, but if you want to study further on, you can refer to ABC Dermatology or your books of medicine for these topics. And if you want to go on online search, then you can study on DermNet NC and the clinical descriptions of American Academy of Dermatology, which will give you very basic and helpful knowledge regarding these topics. Now, as we go on further, okay, why is this not progressing? Okay, so this was, I'll just go on with these. Now, we know that these are the common presentations which come on the skin. From these, the first two are the ones which we will focus on, and these are common infestations. Okay, we have infections, infestations, eczemas, and other conditions, but we are focusing on the infestation right now, which is scabies and pediculosis. First of all, we will go on the scabies version, and we will try to describe it as simply as possible so that you can retain it, and we will focus on the points important from your exam point of view as well. So scabies is a contagious disease, and all those who have done the rotations would be pretty aware of this disease as it presents quite commonly in our OPDs as well. So whatever your questions, we'll deal them in the end of this lecture. So no worries about that. As many as you have, I'll answer all of those. Now, scabies is caused by a mite, which is Sarcoptes scabii, okay? And it burrows into your skin, and acquiring the female is basically responsible for the progression of the disease because it lays eggs and it progresses in your skin. Now, the mite is flattened dorsoventrally, like this. It's creamy. And
lecture
yes,
शेयर नहीं हुआ आपका?
अब मैं इसको क्या करूं?
पहले आप एंड करें इसको, पहले वाला ही शो हो रहा है.
And when you scrape the lesions, you can either, it's a process, you visualize that under the microscope, and you can either get the mite or the eggs or the feces of the mite, which is called scaballas. Any presence of any three of these is confirmatory for scabies. The second is visualizing under a dermatoscope or intense magnification clinically, and that would give us the jet. You can appreciate the mite in that, as well as the jet and contrail sign, which I showed you in the skin lesions. The jet and contrail means if you noticed when the jet flies on the sky and it has this trail of smoke behind it. So that is what it is synonymous with it. And third is adhesive tape technique. It's more or less similar. You just apply a sticky tape, you peel off the skin in the web spaces or the areas where you suspect the burrows are, and then you examine that under the microscope again for the same three features. Now, transmission is basically from person to person, close contact, okay? It can also spread by fomites in the sense that if you're using the same clothing, if you're sharing the same bedding, close physical contact, yes, you can get scabies from one person to the other and from the agents as well. However, fomites, if you do not consume within 24 to 48 hours, then it does not transmit because the mite cannot survive more than that time without a host. So, but we always get the person, whenever we're treating the patient, we ask them to treat the fomites as well, because you don't know what is the quantity of infestation and how much which thing is being used. So it's always better to be very precise or very aggressive with your cleaning and hygiene. Now, close contact, as I mentioned, is one of the modes of transmission, the more physically closely you come in contact, it is said that it's the female mite which transfers the disease. So that is one of the important things. And when you're treating, yes, general instructions are that everyone in the house needs to be treated because it will manifest sooner or later. The more people, the more in contact, it's better to treat all of them simultaneously. Thirdly, even if you apply the medications, it's not like one application and it's gone and then you can't have it again. You can acquire scabies multiple times depending on how many times you come in contact or what your environment is where you're coming in contact. But it is a treatable condition, which is the good part. And every time you apply the application according to the instructions, you follow them properly, you get cured. That is not a problem. So the different agents available are all of these: 25% benzyl benzoate, monosulfuram, 0.5% malathion, 5% permethrin is the drug of choice. Okay, this is the treatment of choice. And 1% Lidin, cotameton, even sulfur 2 to 10% depending is also one of the treatment modalities. Why we prefer permethrin? It is extremely safe. It causes minimal irritation. Very, very, very rare. And a single application is usually very effective, but because it's endemic in our society, we usually apply it more than once. And we ask them to repeat it after a week as well to overcome any remnant ova or anything that would not have been treated previously. Thirdly, you just need a 12-hour overnight application on your whole body below neck to toes, every area covered, and then repeat it after a week. Clean all the fomites, and when you're cleaning all the beddings and towels and everything, we ask them to wash them with warm water and use warm iron over them. The heat is what actually kills the mite. And this thing has to be repeated in all the individuals. The itching may persist for longer because obviously the hypersensitivity phenomena is pretty active. So it does not go away in one sitting. So you continue with the antihistamines for a longer period of time. And again, as I mentioned, just because you are treated does not mean you cannot have this acquire this again. So if you come in contact with someone who has scabies, you can acquire it as many times. It's just the good part is that you can treat yourself well. Permethrin is again safe for neonates, infants, pregnant women. So that's why we prefer this. It is worldwide recommended. Thirdly, sulfur is also very, very safe, but that requires like 3 consecutive applications, 3 consecutive nights. So that also, that becomes a little inconvenient. This is definitely more convenient. But these are all invented. Lindane is, however, not preferred to be used now because of its neurotoxic effects, and it's usually not recommended for children less than 12 years. Permethrin, how it works, it just works as a neurotoxin to the mite. It paralyzes it and causes it to die. Now, antibiotics you only give if it's infected scabies. If it's not infected, there is no point of giving antibiotics. Antihistamine, yes, for symptomatic relief, you can give it for a little longer. Ivermectin is the oral medication for scabies, and it is given usually in Norwegian scabies, the one that we mentioned, which I showed you before, which is like a variant. And if you keep giving the patient topical treatments and he's not responding, or his relapses or recurrences are like really very frequent, then you can consider this treatment as well, along with the topical one, because there may be some point where either the application is not being applied properly or some part of negligence compliance issue. So this would be a safer bet. So this is mostly for scabies. And now the second part, which is pediculosis or lice infestation. Now, these are the 2 main species of pediculosis, Pediculosis humanus and Phthirsis pubis. These are the crab louse, the crabs. And this is of, again, 2 types, the capitis, the head louse, and the corporis, the body louse. Now, again, these are transmitted by close contact, seen both in males and females. Males have shorter hairs, very shorter hair comparatively. So it is a general a view that maybe males do not have lice, but no, we have seen enough males with a lot of lice in their hair as well. And obviously, the longer the hair, the more easier for the lice to conceal themselves. That is why they present quite commonly in females as well. Now, basically, transmission is from very, very close contact. People who share the same combs, the same scarves, sleep together, same pillows, they can have a transmission of head lice. body louse is again close physical contact with people who have hygiene issues, especially because this louse prefers clothes more than the body. It lives in your clothes, in the seams of your clothes. It lays eggs in the seams of your clothes. So basically, homeless people or people who don't clean themselves very regularly or don't clean their clothes are the ones which have this condition more commonly. And crabs is again one of the sexually transmitted conditions as well. So it involves the pubic hair in preference, but it can be seen in other hair areas as well. We'll do that. And whenever you have a patient with crabs, you should work them up for other STDs as well, because if it has one, it could have the other conditions as well. So most commonly, now when we come to the capitis ones and the others, first of all, lice again. The two species vary in morphology from one another. The head lice and the body louse are more longer. They are, as the head lice speaks, it prefers the scalp hair. The body louse prefers the clothes more than the body and on the skin. And it comes on the body to feed and then it goes back in your clothes. So that is what its preference is. The female is again longer than the male. The lifespan is about 40 days, lays about 7 to 8 eggs per day. And the eggs are called nits, and they are firmly attached to your hair shaft, very, very adherent, very firmly adherent. It's not easy to remove them. And when the what you call the larva matures, it kicks off the operculum and comes out, and then it starts feeding on your scalp. Okay. Now, when the lice is moving around, it really does not cause that much of a problem, but when it bites to suck the blood, and the saliva enters your skin, that is what causes the irritation and the itching. So that is what leads to it. If initially what happens is sometimes you have so much infestation and you get so used to it, or you can say so sensitized to that much anymore. And this you can very well see in patients who just have lice and they're not bothered because they're not itching and they're not really concerned. So that is something which we need to keep in mind, that not every infestation presents with excessive itching in these conditions. Now, pediculosis capitis head lice, these lice are mostly present in the scalp. Very rarely you can see them in the beard area or any other hairy area. Why? Because they prefer the thin and slim texture of the hair of the scalp. The hair on different parts of the body have different characteristics. So they prefer the thin cross-sectional area hair, the smoother hairs, and most commonly seen in the occipital region. Why? Because the density of the hair is maximum in that region. That is why. So it's easier for them to hide in that area, right? And transmitted by combs or sharing the same stuff, sleeping together. Yes, please remember that head louse does not jump from one head to the other. It has to move from one medium to the other. It cannot jump that much. So that is a wrong concept. That is something that people assume. One more thing is that people keep saying, rainwater, people who bathe in the rainwater, they acquire the lice generate from that. Nothing like that. It's a living thing. It will follow all the patterns of a living thing. It does not take birth from non-living structures. Long hair, again, because it is easier to hide in them, and infrequent washing and cleaning. Although washing does not make the lice go away, you have to treat it properly. Itching, yes, one of the most common symptoms. And as the infestation progresses and everything, you can see these excoriated lesions on the neck. They can be present along with lymphadenopathy. And secondary infection can also be there because of progressive itching. You can present with scalp folliculitis and other infected conditions as well. Now, pediculosis corporis, body louse, or vagabond's disease. This is another name. Vagabonds, homeless people, non-hygienic conditions, all positive factors for this condition. Lives in the seams of the clothes, as I mentioned. You can see this thing, the lice and the eggs would all be there. Transmitted by clothing and bedding more. Usually the lice can live 36 to 48 hours without a feed. So during this time, it can be transmitted easily from one object to the other. If it's longer than that, like a week or so, then they will die within the clothing as well. So that is something you need to keep in mind. Pruritus, again, one of the commonest symptoms. Can present with papules, excoriation marks, secondary infections, and secondary pigmentation can also be present because of repeated itching. Okay. Third is phthisis pubis. Now these are the crab louse. Why? Because the structure resembles the crab. They are like more broader and they have pincers on the front legs, which help them to hold the thick air of the pubic area and progress. That is why they are called crab louse. And you can see they are more broader and not slender like those rices. These pigmented marks are called maculae caerulea, which is one of the diagnostic clinical findings of phthisis pubis. Transmitted by close physical contacts, usually sexual, and itching can be present anytime, mostly during night, but can be anytime. And the nits, one more thing, the nits or the lice eggs in both the capitis and this are closer to the roots. That means it's an active infestation. If they are like really, if they're not close to the roots but far off, it represents an old infestation, meaning the patient has been treated, and probably these are remnants of the what you call nits, which are just adherent to the shaft. But the closer the infestation to the roots, the more active the infestation it indicates. The crabs may also infest the eyebrows, lashes, beard, axilla, and all these areas because these are all thick hairs. Scalp hair, very, very rarely by crab louse. Usually the margin may be there, but the hair are very, very seldom infested by this. You can appreciate the nits on the eyelashes. Now, again, the general measures, you have to delouse the clothing and the bedding. Yes, the whatever structure is in contact with you, it has to be treated along with you. For the head lice, you apply permethrin overnight application, repeat weekly, and it works well. Why we repeat weekly? Because the nits, they are resistant to any form of treatment as long as it has not hatched. Once it hatches, the nymph comes out, then it is susceptible to the what you call this insecticidal action of the application. Treat the clothing with warm water, use warm iron after that. That helps in killing the nits as well as all the living ones. Again, antihistamines should be given because itching is something that needs to be addressed. These are all the options. The preferred treatment is permethrin against treatment of choice. However, if there is extensive infestation and sometimes you can actually see the lice running on top of the hair, it's like very, very heavy. So then we give ivermectin along with permethrin. That is the oral treatment option and works. The dosage is the same. The method is the same, weekly dose, stat, but it works really well. And one more thing is if it's pubic louse, then shaving the area of infestation works well. But obviously if the eyelashes are involved, that's not possible. Then you can just apply petrolatum overnight and that sort of asphyxiates the larva. Thirdly, if it's scalp lice, head lice, then again, shaving in children is a good option if it's very extensive. Otherwise, this works well. And anything, these are all the basic things. If there's secondary infection, then you give an antibiotic. Otherwise, really no need for an antibiotic. So this was the main discussion on both the main topics. For you, this is like sufficient, and you can read these chapters in Davidson or ABC Dermatology or the sites that I told you, which would give you enough. If else there is any question, then you can definitely contact us anytime in our department and we'll be happy to help you as well. So if there are any questions, I can answer them side by side. Wajad, can you आप उसको on screen कर सकते हैं questions को अगर हैं?
जी मैडम, मैं चैट ऑन कर रहा हूँ.
ओके, क्योंकि मुझे नजर नहीं आ रहा है.
ठीक है. जी मैडम, नजर आई?
नहीं
मैडम, मोर में ही चैट का ऑप्शन भी आ रहा होगा.
मोर में नहीं, मोर में चैट का ऑप्शन तो नहीं आ रहा. मोर में आ रहा है शेयर साउंड, ऑप्टिमाइज वीडियो क्लिप, मीटिंग इन्फो, रिएक्शंस. चैट अच्छा चैट रिएक्शंस के साथ ही है ओके 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 ठीक है मैं स्टार्ट करती हूँ स्टार्टिंग से अच्छा स्लाइड्स तो अब नजर आ गई ये तो सारे इनकी प्रेजेंटेशन है The website is DermNet NZ and clinical presentations of American Academy of Dermatology. These are the two websites where you can get good information. We don't give antibiotics in general for scabies. Only when it's infected scabies, then we give antibiotics. That when you secondary infected scabies, secondary to itching or whatever. Does permethrin kill both the adult and eggs? Permethrin kills the adult and the nymph, but as long as the egg is not hatched, that won't kill the mite inside the egg, the nymph. The egg has to hatch and the nymph has to come out for it to be affected by permethrin. Okay. Type the sites which you can. Okay, I'll try to do that. Yeah, the presentation will be, both the presentations will be uploaded and you can visualize everything. You can go through them, read them, whatever. It will be available for you people all the time. So you don't have to worry about that. Okay, ivermectin we give as a stat dose depending on your weight and age. That is a specification, but we do not give ivermectin in anybody who's less than 15 kg. So it is not given in children less than 6 years of age or anyone who's less than 15 kg. Okay. Initially, we give it at a stat dose, that is once, and then we repeat the dose after 1 week. Okay. And that is the same protocol for extensive scabies and for lice infestation. Within a year, yeah, you can repeat it within a year's time. That is not a problem. Depends on if you have the disease. If you don't have the disease, then obviously you will not be repeating the dose again and again. Is topical application or using a shampoo? No. Please keep this thing in mind. Shampoos for pediculosis are not recommended at all anywhere. Why? Because the concentration of the pesticide is very, very low and your contact time is very, very less. It's like a few minutes hardly. And in this way, you will actually be inducing resistance in that organism on yourself. So using anti-lice shampoos is a total no-no. Okay. Well, if there is lice infestation, use permethrin for 12 hours overnight, works great, or we can give you a different compound as well. But do not use anti-lice shampoos. They are actually one of the causes of emerging resistance to the treatment of active pediculosis. Not recommended at all. Okay, can you please, oh, okay, I'll just write it here. I think, yeah, for DermNet NZ and another one is up to date if you want. Okay, that is another very good one. Okay, next, permethrin for lice infestation and scalp will be applied on scalp only. Yeah. If it's only scalp involvement, you will only apply it on the scalp. If it's body involvement, you'll use it for the body. Okay. Whatever the side, but if it's for the body, you'll use for the entire body. And more than the this application for the body louse, it's the cleaning of the clothes and the foam, whatever your contact elements, that is more important for body louse. Okay, just a second. Let me see where I was. Okay. Does permethrin have local side effects? Permethrin hardly has any. It's one of the safest applications approved. It's approved in neonates, so obviously it's one of the safest applications. We have not seen any side effect to permethrin to date. We have I don't even know how many patients of scabies we treat daily, but it's like, as I mentioned, the load in the OPD is about 72% for both the conditions. So it's very, very safe in pregnancy, infants, neonates, anyone. It is stated that it may cause slight erythema or irritation, but frankly speaking, not so. Okay, what will be the duration of treatment of scabies? Scabies, again, the same way, we apply 12 hours overnight, neck to toe, every area of the body. And Then we repeat it again for the next day, and then after 1 week. Why? Because we don't know, because the eggs usually take about 5 to 7 days to hatch off. So we need to treat the nymphs as well. Otherwise, they will mature and will result in the same manifestation. So you have to repeat the application. That is maculocerulia. I think that will be given in your books as well. Don't worry about that. Can't we remove the legs? Yeah, the nits you mean, right? Yes. One of the methods of removing the nits is manually. You apply oil and you sit and you remove them. It's time consuming process which you have to use like for a couple of days. Fine combing is one of the methods that you can use for treating lice again, but permethrin is way simpler. Thirdly, again, if there is a secondary infection in your scalp, then combing will cause further pain, discomfort, and it won't be possible. So that is an option you do when the secondary complications are not there. But yes, fine combing is something you can use routinely as a screening at home as well, for screening at home as well. Actually, brand names I cannot mention here, although it's very freely available. And recommended dosage is like, you apply it, you take a bath in the evening with lukewarm water, apply the cream from below neck all over your body, front, back, everywhere, leave it for 12 hours overnight, and then you take a bath in the morning. Every time you take a bath, you're supposed to change your clothes, use clean clothes every time. Whatever clothes you take off, you have to put them in washing. Whatever towel you've used, you have to put them in washing. Whatever what you call linen you've used during the night, you have to put in washing. That's how it works. I've added the websites. I think you can see them now. I mentioned lice combs can be used as one of the treatment modalities. You can even use it for screening yourself at home as well, once a week or once in 15 days, especially for school-going children. But if it's an active infestation, then permethrin just makes it more simpler and easier to use. It's much, much easier and convenient as well, and cost-effective also, and time-effective as well. Nodules and nodulocystic. Okay, nodule simply means a raised lesion inside the skin involving all the layers of the skin. It's a thick, solid lesion in the skin. Cystic, as we know, is a term which means a cavity which contains semi-liquid or semi-solid substance, and it has an epithelial lining. Okay? So a nodule is a solid one, and cystic is like a hollow cavity which contains semi-solid or semi-liquid components. Head louse, as I mentioned, you will just apply the application overnight. We recommend the patient to wear a shower cap over the after application overnight as well, or tie a cloth, and the next day take a shower or and wash your hair. That's at 12. After 12 hours, you can wash your hair, no problem. Okay, I'll just mention them again because I have written the sites, but I think some of you can't view it. So the site is DermNet NZ and UpToDate and American Academy of Dermatology Clinical Guides. They are simple to remember. Any one of them you can go on. It's equally the same. Doesn't matter. I think I'm done with all the questions now. Okay. Infected scabies is when the scabies lesions become secondarily infected with a bacterial infection. Okay, you have scabies, you're gonna itch. When you're gonna itch, you're gonna abrade your skin. When you're gonna abrade your skin, the surface barrier is gonna be disturbed, and the microorganisms can enter your skin and cause a secondary infection. So you can have secondary infected scabies, like you can have impetigonized scabies or scabies with folliculitis or whatever. So that is what is meant by secondary infected scabies. Okay. Thirdly, shampoos are not recommended for lice. Okay. Any shampoo having any permethrin or anything is not recommended. You will apply that water hardly for 5 minutes and then rinse it off. Not recommended. You have to use an application for a longer period of time for them to actually be effective. Okay, you're welcome. I think we're done with all the questions. If there's none, then we can just call it out. Welcome. Okay, I think Wajahat, I think questions सारे हो गए.
ठीक है मैडम, एंड कर दूं?
हाँ जी, मेरे ख्याल में कि अब और कोई नहीं है. ओके, एंड कर दें.